Hello, I'm Dr. Lisa Radasta. I'm a board certified veterinary behaviorist. And today, during this learning session, we are going to talk about one of my soapboxes, generic versus brand name medications, and how we as clinicians can make really good decisions for our patients so that we have the very best outcomes possible. So we'll start with a case, and then we'll move into learning a little bit more about the difference between generic and brand names. And then we'll finish up with several more cases. So it's a really clinical learning session today. We're going to start with Eddie. And what you should know about Eddie is that I saw Eddie as a referral. So the primary care veterinarian did a lot of these adjustments and a lot of the work that involved the medicines before Eddie actually came to me. So this is what happened at the primary care's office. Eddie presents for barking in the crate when alone. He's basically overreactive, hyperreactive, right? He's fearful of random things. He's about a 24-kilogram male neutered husky, by the way. And so the primary care veterinarian does her due diligence. She makes sure that he's healthy and she puts him on Reconcile 1.3 milligrams per kilogram by mouth once a day. And the outcome was like amazing, right? Barking in the crate was eliminated on day one. I do want to say you'll learn later in the session that I don't usually start dogs at this dose. It is within the dosing range, so it's safe to do so, but it's usually not my choice because I see less side effects and more client buy in, probably because of the less side effects, if I start a little differently, which I'll talk to you about later. So, as happens with pet parents, the pet parent thought, well, if some is good, more is better, right? But not always. Because when we make these big jumps, as this pet parent did, to doubling the medicine within 2 days, we start to see side effects. And she did see that her dog was calmer, which of course she loved. But the problem is that her dog was also a little agitated and a little more fearful. And so, rightly so, the primary care veterinarian went ahead and brought that medicine back down to 1.3 mgs per kilo once a day. We see that Eddie stabilizes, he's improved. This goes on for another, 3.5, 4 months. I mean, we are doing very well. Then at around 4 months, the pet parent approaches the primary care practitioner and says, hey, let's wean my dog off. This, again, for me is a little bit early. I try to wait until I have a completely stable patient for 3 to 6 months. So 4 months is a little bit early. And also keep in mind that your definition of stable is also going to affect when you do this wean, right? So my definition of stable is 3 to 6 months where the pet parent is completely happy with the dog's behavior and feels like they are working minimally, right? And if that is not the case, we are not truly stable. So this is a little bit early and it's frankly just a little bit short, 5 days, right? Now you can take dogs off of Reconcile very quickly if it's been 2 months or less, based on the FDA approval study for this drug. However, I find this to be a little short, right? If we don't need to go that quickly. And of course, what do we see? Side effects, some of those rebound side effects. So the primary care practitioner says, no worries. Let's go back to 1.3 milligrams per kilo PO once a day, and let's hang there for a while. Now we see some improvement, but we really don't see that stabilization again, which I find very interesting because this is not new to me. Not just with Reconcile, but with a lot of behavior medicines, when I decrease or wean the pet off, especially if I do it really fast, I can't always regain that improvement that I did before, at least not with the same medicine at exactly the same dose. So you'll also see at 5 months that the primary care practitioner changed from Reconcile to fluoxetine. This is also very common that a pet parent at some point when her dog is doing well will ask for the generic. And, that's sort of, I put it in the same bucket as kind of complacency, right? So if let's say you're trying to lose weight, you get to your goal weight, you feel great, and then you go back to eating the way that you were before. That doesn't really work, right? And it's the same with behavior medicines. If the behavior medicine helps you get to where you're going, your pet will probably need that medicine, not definitely, but probably at some point throughout his life for a certain amount of time. Okay, so primary care makes the switch to fluoxetine and we see regression. So the primary care not knowing if it was due to the switch to the generic or that we couldn't regain that initial stabilization, she increases to 1.5 mgs per kg POQ24. But the problem is now the dog's got side effects. So we have a problem. We have not gotten our stabilization back, and now our patient has side effects. So at 7 months, she goes, I don't know. Let me refer to Dr. Radasta. And I put the patient on Reconcile, right? Back to 1.3 mgs per kilo, because what I told the pet parent is, I don't know. I don't know why your dog is having side effects. I don't know why your dog has not regained that original stabilization. So let's go back to square one and let's try out that original dose that worked. And voila, 14 months. So 7 months after I put the dog back on Reconcile, dog stable. Okay, look, everything is not this neat and tidy with this bow on top, but let's just talk about what actually happened here in this particular case. Okay, so what you need to know is that generic medications are a copy. What you see on your left is the real Mona Lisa. What you see on the right is the first copy from Prado, Spain. And you can see they are both really beautiful masterpieces, but they're not identical. And generic medications are not identical to branded or FDA approved medicines. And by the way, they don't have to be. No one's doing anything wrong here, right? They do not have to be identical. They're a copy. So I ask myself, and I ask the primary care practitioners that I teach when there's an FDA approved medication available, do you recommend it instead of a generic? I do 100% of the time. Why is that? Because, like the majority of veterinarians, being a veterinarian and being a veterinary behaviorist is not a career choice, it's a calling. It goes to my core values. It seems like 6 years old is the magical time where vets go or kids go, I want to be a vet. Like when you talk to people, they say, yeah, I was 6. That's pretty basic. Yeah, I was 6. So, we live to do this. This is a part of who we are. And for me to shirk away from my core value, which is helping pets and their people live less stressful lives by deliberately choosing something that doesn't work as well, that doesn't make a lot of sense to me, right? Now, sometimes pet parents will ask for a script for a generic, and I'll talk to you about how I deal with that later because obviously, 100% of the time, I am going to help that pet, and that may mean writing a script for the generic, but we'll talk about how we discuss that later. Now, FDA approved medicines, branded medicines, I'm going to use those interchangeably in this learning session. FDA approved medicines and generics must be bioequivalent but not identical. So, what in the world is bioequivalent anyway? And what do generic drug manufacturers have to prove when it comes to bioequivalence? All right, so what you're going to see on one axis is you're going to see the amount of drug in the blood. Okay, then you're going to see time on the other axis. And that big AUC, those initials are area under the curve. Basically, what area under the curve means is the dog's exposure to that drug in the blood and what that looks like. When does it peak, right? When is it completely eliminated? All right. So, what the FDA requires for bioequivalence is that the population mean values, okay, so that's the average value. Population mean is the average of all the dogs that were in the FDA approved study. Okay, with me? Population mean value for the area under the curve and the peak concentration, that's where the drug hits the very highest it's ever going to hit in the blood, okay? That those two parameters for the generic be not less than 20% and no greater than 25% of the population mean values. What does that really, really mean? It just means that we don't know how much drug is in that capsule or tablet. We don't have a clue. We don't know if the generic drug, is going to peak at the same time as the branded drug. We don't know if it's going to be eliminated at the same time. We don't know where that area under the curve is going to shift to the left 20% or to the right 25%. They are not identical. So bioequivalent means they have to have the same ingredients, all right? And the same ingredients meaning active ingredients. There can be other ingredients. Those other ingredients can be anything. And if you're a parent of a child that has any sensitivities, you already know that binders, fillers, colors, preservatives make a difference when it comes to side effects and reactions. Companies have to say, they have to attest, and they have to show with some sort of study that the medicine that they're proposing as a generic works in the same way that the branded does. Be careful here. Works in the same way. My Ford Explorer SUV works in the same way that my husband's BMW, I don't know, super special M3 something or other. I don't even know the number that it is, but they work in the same way. But my husband will be the first one to point out to you that they are in no way identical. The driving experience is not identical. They are vastly different. Okay. So, for example, Clomicalm is a medicine that is approved for use in dogs for separation anxiety. The company that brought the generic Clomicalm for approval by FDA did one study with one 20 milligram tablet. In other words, they didn't test all the different sizes, they didn't test different dosages, and they did a single dose study as compared to what it takes to bring a drug to FDA approval, safety study, which is usually at least a year. In Clomicalm's case, they did a cardiac study as well. And there's also the study that gets the label, right? Labeled for XYZ. So bioequivalence is not the same as therapeutic bioequivalence. So generics do not have to show therapeutic bioequivalence. They are not required to show that the product works exactly the same way. They're not required to show that the patient responds to the drugs in the same way. They're not required to assess the adverse events from inactive ingredients. And you don't have a technical services veterinarian to report to. You can report any adverse events right to the FDA. I've been a vet for over 2 decades, well over, and I've never reported an adverse event to the FDA. I think that it's easy for us to pick up the phone and call one of our manufacturers of a veterinary medicine. It it just seems harder. There's just more friction to trying to figure out how to report something to the FDA, right? So let's talk specifically about Reconcile versus fluoxetine. We do have evidence from the Reconcile 1 year safety study that compared fluoxetine and Reconcile, that actually fluoxetine and Reconcile in general are about 15% different when it comes to bioequivalence. So you have a pretty good indication when you pick up any generic of fluoxetine that there's going to be at least a 15% difference in that product. And from generic to generic, that is going to vary. That affects your outcomes because you don't know how much you're giving the patient. You don't know. You don't know if an adverse event is caused by the medicine or if the patient is having an adverse event because of a filler or just something else going on in its life, which often happens with behavior problems. We have to parse out, is the animal more afraid because something's going on? Is it the medicine? Is it an adverse event? So using a generic really complicates matters. And we'll talk about when you only have generics as a choice, which unfortunately is often the case in vet med, but we'll deal with that a little later. So let's look at a more detailed case than Eddie. This is Butters. Butters was a case that I saw from the beginning. Okay. Butters is a 2-year-old female sprayed mixed breed dog, 18 kilos, comes to me because the dog is aggressive toward the cat over items and also has a separation related problem. I diagnosed this dog with isolation fear, fear induced aggression toward other dogs, and possessive aggression toward the cat. And as always, we are going to work our patients up. So we worked this patient up, CBC, a chemistry, a good physical exam, thyroid, a fecal DX, and we also always look at a urinalysis. So I want to highlight to you, even though this is a medicine lecture, that every single case that I'm going to present to you today, and I would say 99% of the cases that I treat have some sort of behavior modification or management of the environment as a part of treatment. So when I show you that an animal is stable or that they've responded, always keep in mind we didn't just do medicine. It would be lovely if we could fix behavior problems with a pill. So far, we have not figured that out, but medicines or pills, right, or capsules are part of that big picture that we use to help animals just feel so good and overcome their mental challenges. Okay, so this particular pet parent on that first day went home with several drugs. I sent her home with trazodone. Why? Because I needed to quiet the separation related behavior immediately. Trazodone, remember, is an antidepressant, but in people it's used as a sleep aid. And in dogs, it does the same exact thing. It helps dogs sleep. Because this pet parent is gone for a long amount of time, like leaving for work for 8 hours, I needed something that lasted a pretty long time. And trazodone is one of our few medicines I can count on to last a long time. Now, trazodone is a little finicky. It has to be given on an empty stomach. That is super important. And really, you've got to get it in these patients a minimum of 2 hours prior to departure. So you need clients who can get up early or who don't leave very early in the morning. You can see I also gave the client a range because I want her to feel empowered to move through a safe range and not have to call me every 5 minutes when she really just needs to know if it's safe to give that next dose. So we leave it up to the client and we give them pretty specific recommendations about how to increase that medicine. I also sent her home that day with Reconcile. Now, even though she went home with both of the medicines at the same time, we never start two meds at the same time. That's not safe, right? So we started the trazodone, and then 3 days later, we're going to go ahead and start that Reconcile. You can see exactly what I did here. I put the dog on a lower dose, and I slowly increased to a higher dose. And even my higher dose, in air quotes, is not even 1 mg per kilo. Why would that be? Well, I dose this way for lots of reasons. Number one, I think as experts, as specialists, we are trained by our mentors, and this is the way my mentor dosed. So already it's ingrained in my psyche that this is the right way to do it. But I've been out of my residency. I've been boarded since 2006, so a very long time. And so why do I continue to do this? Because Reconcile appears to me to frequently work at less than a milligram per kilo. And I always like the lowest effective dosage. So why am I in a rush? Second of all, this medicine takes 6 weeks to work. If I give a dose that is higher initially, I have a high probability of causing side effects that the client won't like inappetence and sedation. So if I cause those side effects and the client gives up, and a lot of clients will, and I don't disagree with their decision to give up on that medicine, then I lose the chance to use that medicine to really help the patient. If I start low and go up, then I have a low incidence of side effects. The drug's going to take 6 weeks to work no matter what I do, and I get to the same end game, happier pet parent. So there you go. Now, dogs don't get better just with medicine, as I said. And so you're seeing how often this dog has worked with my team in the process of getting better. So 3 appointments with the behavior team happened over the next 3.5 months. Those are my technicians. We call them, tech rechecks or tech progress updates. And the pet parents also working consistently with a positive reinforcement certified dog trainer. So there's a lot of things going on behind the scenes with Butters to help her feel better. In 5 months, she comes back to see me, and look at this. Wow. Okay. Aggression to the cat is resolved. Isolation fear is significantly improved. She can leave for 45 minutes without giving trazodone. Okay, that's not bad. But as you might have guessed, she would like to leave for a longer amount of time than 45 minutes without actually medicating the dog. And so, what I asked her to do was to increase that reconcile. Okay, so you'll see her current medications there. She's getting zero point 0.9 mg per kilo once a day of reconcile and 100 milligrams, that's 6 mg per kilo PO before departures, 2 hours prior to departure. So, what do we do next is the question. Like I said, I went ahead and increased that reconcile and I lowered the trazodone. So I increased the reconcile really just slowly up to 20 milligrams from 16, but sometimes a little bit Goes a long way, right? And when I did that, I lowered the trazodone to sort of test, hey, maybe we don't need the trazodone. Let's see if we can slowly wean this dog off of that drug. What you're probably noticing now is that Reconcile does not come in a 20 milligram tablet. No. So I am at this point telling the client to break tablets. Okay, let's spend a moment on that. That is called extra label or off label use. That's when you use a drug for a purpose or in a way that the drug company did not get authorization for and does not recommend. And in vet med, in behavior, I would say 75% of what we do is off label. In vet med, I don't know, it might be 50% or maybe it is 75. We are flying by the seat of our pants sometimes. And so when you use something off label, like I did here, you accept the responsibility for the fact that you dosed it that way. We also recognize that when pills are not scored, the manufacturer is not guaranteeing that the same amount of medicine is in each part. So in this case, I had this patient on a 16 milligram tablet. She's getting 1 1/4. When she breaks it into that quarter, that could have 0 Reconcile and it could have 16 milligrams of Reconcile. I fully recognize that and I try my best to not have clients break tablets that aren't scored. Nonetheless, I do use this product extra label just like this. And because of the way the product works, I and the fact that I'm always well within the dosing range, I have very little concern about it, but it is your responsibility whenever you do anything extra label. 3 more months go by, and she is meeting with my behavior team basically about once a month, and she's working consistently with a dog trainer. 8 months, she comes to see me. Look at that. That is beautiful. That is beautiful. Her dog is doing extraordinarily well. She basically doesn't need trazodone. We're just keeping it in case we need it. And she does what so many clients do. Let's switch to the generic. Oh boy. Okay. So what do we do now? Well, look, as far as I'm concerned, clients drive the bus. When we're in that appointment, they are in charge of their pet's care, and I don't make any decisions for them. And I also don't try to like bully them or push them into making the decision I think is right. So I just laid it out. Here's the risks. The risks is that Butters is going to relapse. The risk is that I will not be able to get her back with the same amount of Reconcile. And that is a risk because we're talking about aggression here. This isn't just a separation related problem. That's bad enough. But we're talking about aggression to a cat who's a lot smaller than she is. So this is not what I would recommend. Yet, that's what she wanted. So we started fluoxetine the very next day. We discontinued Reconcile, started fluoxetine the next day, once a day, 20 milligrams, same exact dose, because we don't know what we're dealing with. So I'm not going to be changing the dose as I make this switch. So then I see her 10 months out from that initial presentation, and she's looking pretty stable, except the aggression to the cat came back. And what you see in bullet point 4, family gives me an ultimatum. As a veterinarian, look, we've all experienced this, right? People get frustrated, family pushes to have something happen, then they threaten euthanasia or rehoming. This is not every day, but this is not uncommon. So I explained what I think happened. I really think, based on the history, that this coincided with the change from Reconcile to fluoxetine, and I really wanted her to go back on Reconcile. And she said no, which is what happens sometimes, right? And so I said, okay, well, I'm going to go ahead and increase that fluoxetine, and I gave her again, empowering her. I gave her a scale. So you're going to go up to 25 milligrams by mouth once a day, and you're going to do that for 2 weeks. If you feel like your dog's stabilized and there are no side effects, don't go any higher. If your dog isn't stable or you see side effects, go ahead and go up to 30 milligrams once a day, right? Well, so she ended up landing at 25 milligrams once a day, and she was able to stabilize this particular dog 18 months out. And the dog is still stable today, which is well beyond this. So, we can't always persuade clients to go back on the drug that we know worked. In this case, it worked out really well, and I am completely grateful for that. What is frightening is what if she had not called me? What if she had gone to the primary care who didn't know what to do? What if, and this dog had been euthanized? So that's always my fear, but I'm really glad that this worked out well. Okay, Miss Pinky. Miss Pinky comes to me at 8 months old, female intact golden retriever, 26 kilos. I am seeing, you know, more and more golden retrievers. I mean, certainly not as much as other breeds, but I'm seeing more and more that have behavior problems. And on their list of behavior problems, more and more is aggression, which is really disappointing and sad. But Pinky's a lovely, lovely dog. She just has that little bit of aggression that can be disconcerting. But her pet parent brought her to me really young, which is absolutely the way to go. And so these are our diagnoses. She's got fear induced aggression, as pretty much every dog who comes to see me does. This displacement behavior, a generalized anxiety, which makes it look like she's hyperactive, but in fact, she's just really anxious and kind of displacing that anxiety into this nervous business. Okay, we always work our patients up, of course. And Pinky was no different. Okay, you see my standard work up there. Now, even though on that first day I explained to Dad that we intervene early with puppies and we start them on antidepressants, by the way, totally off label use because this dog does not have a separation related problem, right? But still, we do use Reconcile and Clomicalm and sertraline and paroxetine and lots of other antidepressants in puppies for aggression, for nervousness, for anxiety, etc. Okay, but like many pet parents of puppies, he really didn't want to put her on an antidepressant. There's that friction when you hear antidepressant, right? That you think it's a strong drug, which is really not true at all. But we chose a not very strong drug, gabapentin. It can be very effective, but it's gone from the body in 8 hours, pretty gentle on the body. So that's what we chose, and we started that. And as he met with my behavior team and was working with the dog training professional, it became apparent that gabapentin was not going to work out for us. Pinky was having kind of a paradoxical reaction to it where she was getting more energetic, which obviously we don't want that. So then we switched to pregabalin. It looks like I just went straight to 100 milligrams, but that's not the case. We started at 25 milligrams by mouth twice a day and slowly worked up to 100 milligrams. Again, I empowered the client and told him, look, give 25 milligrams twice a day for 3 to 5 days. If you don't see a 50% change and you don't see any side effects, increase to 50. And then kind of we went up from there. So at a month, he comes to see me and I'm like, look, man, I think we have to intervene early. There's evidence in children that intervening early with medicines can actually change how their brain develops. Like, this is very exciting. Please, we should do this. So he says yes. So IRX out Reconcile, 32 milligram tabs, half a tab by mouth once a day for 14 days, and then one tab by mouth once a day. So here we are starting her at lower, she's 26 kilos, remember, at lower than a milligram per kilo, which is perfectly fine, and then going up a little bit, right? A little bit over 1 mg per kilo. However, in this particular case, when I rechecked this dog 5 months later, and I think, after seeing the way I handled Butters and how I saw the dog so frequently, I think that you probably already know that I recommended more frequent rechecks for this dog. Sometimes people don't come back for whatever reason, they're on vacation or finances, but this time he didn't come back because his dog was doing well. He was just like, I don't need to go back. He said, just thinking, hey, common sense, I don't need to go back. It turned out that he had settled on a half tablet. He saw some sedation and appetite decrease on that one tablet, and so he didn't like that. He knew, because I had empowered him with information, that he could go ahead and decrease back to a half, and that's where she had stabilized. So we all good. I'm like, okay, come back in 6 months. So I happened to see the dog in a year, from when I first saw her. So 7 months from that 5-month recheck. And instead of it just being a regular recheck, Dad says, hey, um, she's gotten really aggressive. She's launched herself kind of onto the couch to bite someone. She's been aggressive to us in our bed. This is not even like her. Nothing has changed in the environment. And so as we started talking, the pet parent said that he had on his own, between 6 months and a year, increased the Reconcile to 32 milligrams. This happens all the time. Clients are going to change their pet's medication all the time. I had already told him that he could have done that. It's not a big deal. It's just something to note. So then he goes to his family veterinarian for that yearly checkup, right? And the family veterinarian had sent him home with a prescription for fluoxetine 40 milligrams. So 40 milligrams is a little more than 32, obviously, right? And so he says, give that by mouth once a day, yada, yada, off you go. Well, what we figured out from the history was that this change occurred about a month prior to when Pinky relapsed. So I said, what are we doing? Reconcile is not that expensive anymore. It really isn't. It's quite affordable for the past, I'm going to say, at least 5, maybe 10 years. Please start your dog back on Reconcile. And unlike Butter's pet parent, Pinky's pet parent said, okay, that sounds fine, let's do it. And so with that, we're able to stabilize again. So that's two different types of cases. One where we had to continue on fluoxetine because of pet parent preference, and the other where the pet parent was willing to move back to Reconcile. I want to talk to you about Gus. Gus was not on any branded product, but I want to keep in the back of your head that veterinarians script out a lot of generics. And it's not just because we don't have brand names, it's because sometimes we only have generics, frankly, and sometimes we're being marketed generics, right? So a company is marketing some generic version of a branded that we already have in pets. Okay, so Gus presents to me for aggression toward basically anyone who's not family, including dogs. Okay, and so Gus gets stabilized on venlafaxine, and we used to carry, when my practice was open, we carried venlafaxine and we always bought from the same manufacturer. So I always encourage clients, hey, buy from us, okay? Because we're always buying from the same manufacturer. I don't remember how, frankly, this dog ended up with a prescription with my signature on it, but apparently they requested it or something. And so they went ahead and filled the prescription at a human pharmacy, which a lot of clients opt to do. And then they said suddenly, air quotes, it's almost never suddenly, by the way, suddenly their dog is anxious, hypervigilant, eating grass and gulping air. So not only do we see the behavior side of it, anxious, but we see the nausea side of it too, don't we? Right? Okay. So then they come back to us and I say, okay, first thing you got to do is you have to check and see if your pharmacy has changed from one generic brand to another. This concept is foreign to people. They're like, what? Generic's generic. I'm like, no, there's all these different companies that make generics. You have to go back. Now, just tell people, take a picture of your tablet, and then your tablet should never look any different. Okay? All right. Turns out, in fact, the pharmacy did change their generic brand. I said, look, I know what brand your dog needs. Just get it from me, for God's sake. It's not that expensive. And indeed, we did that. The generic brand that he ended up needing was Tiva. As soon as we changed back to that generic brand, side effects resolved. This dog was stable for another 14 months, at what point he was lost to follow-up because he didn't need me anymore. All right, look, always recommend the FDA-approved product. Be cautious when switching from one to the other. It's so important for pet parents to have information. This is vitally important to them. Empower them with information and then let them make their own choices, knowing what the ramifications, positive or negative, of those choices will be. Okay? When a stable patient relapse, 100% of the time, check the drugs first because you'll solve a lot of what feels like big problems really, really quickly by just knowing where those drugs came from, whether they're on generic or on brand. It was my pleasure to talk to you today, and make sure, if you want more information, to follow me on Instagram, Facebook, LinkedIn, or YouTube at Dr. Lisa Radasta.